Here it comes.
There you go. I see us.
All right. Hello, IHC and digital world. Welcome to another edition of IHC Live. Today, we just want to thank Bard for our sponsorship. But more importantly, I also want to thank and introduce two people who really don't need an introduction, although tonight they get it. Dr. Scott Roth. What's up, buddy? Scott is a professor of surgery now. He's actually the chief of general endocrine, metabolic, and MIS surgery at the University of Kentucky. He is a world-renowned expert in abdominal wall and inguinal hernia, and he'll be discussing complex abdominal wall hernia. And here to help moderate is another amazing and well-known world-renowned surgeon. If you haven't heard of him, you probably are not doing hernia repairs, but Dr. Yuri Novitsky, otherwise known as the founder of the transversus abdominis release. He's a professor of surgery at Columbia, and does a few hernias up there. Stole all my business. Thank you, Yuri. So I wanted to start because, Scott, it's kind of rare that we get somebody from Kentucky before we dive into the hernias. I just want to know if Kentucky is known for anything, specifically any kind of cocktail, any kind of drink that you could just enlighten us on before you dive into it.
Not related to horses. He's going to talk to you about horses.
Now, first off, Brian, I want to thank you for hosting this tonight, and thank you to the IHC. Thanks to Bart. It's a pleasure to be here, and it's always a great opportunity to have a little bit of banter. I look forward to having a conversation with you and Yuri and discussing my thoughts on hernia. But if we want to dive into bourbon, by all means, we can do that. I would encourage everyone to come out and visit and take a tour of the Bourbon Trail. It's conveniently located halfway between here and in Louisville. I certainly have a laundry list of favorites. That's always a good question. What's your favorite bourbon? And if you just have one, you certainly haven't tried enough. So
it's funny that Brian and I have a drink in hand, and Scott is working, obviously. All right. Thank you, Brian. I want to join Scott to say thank you so much for organizing this, for providing the platform for IHC to host this, and for a kind introduction, and for still talking to me, given the fact that I probably saw about 7 people who went to see you and then came to me. No, I'm just kidding. I love it that we're now so close, and the world is much smaller than even it used to be, and tonight we're going to prove that yet again, that we're all one happy family doing really cool and fun stuff for a living.
Absolutely. Yeah, for sure. Well, let's start by diving into Dr. Roth's experience.
All right, I want to start as a moderator. I was kind of charged to watch the talk, and I hope all the kids in the classroom did that too. And it was a really tour de force, a review of all the pertinent literature, and as we talk briefly, as you watch that continuum of information of the data. And it was a really tour de force, a review of. So I became. And as we talk briefly, as you watch that, you guys have echo. Is that normal? I think I can hear myself.
I turned it off. Go
okay.
On.
So this thought that comes into mind, that how much things have changed and how much we have changed. And I asked you, to try to compare and contrast Scott Roth of 7, 8, 10 years ago, who at that time was a recognized hernia expert, providing cutting-edge hernia care to his patients, and Scott Roth today. Tell me a little bit more about this transition and about that little Scott Roth from a decade ago.
Yeah, I think that's a really interesting topic to think about, Yuri. We really finish our training and we think we're at the top of our game. And I think it really speaks to the fact that medicine, surgery in particular, is an evolution, and it's a never changing practice. And obviously that is why we call it the practice of medicine. I think about the things that I learned when I did my fellowship with Adrian Park, the laparoscopic ventral hernia repair with a bridging mesh using PTFE products, and the outcomes that we saw with those. And although we thought we were doing a great service to our patients, if you stick around any institution long enough, you certainly found that those patients weren't happy. Many of them recurred, and there were real challenges with that. And when I started my endeavor in hernia, it certainly wasn't on purpose. I think about, my initiation into the world of hernia really was based on laparoscopic hernia repair. I sat down with a old mentor, Walter Porres, and he asked me what I wanted to do in my first job. And I listed off a bunch of things that every new general surgeon might want to do. And he told me, you can't do that, you can't do that, you can't do that. And I said, well, I learned this laparoscopic ventral hernia repair technique. He said, you can do that. I'm happy to let you have all of that. And we shared a clinic space, and he was doing open gastric bypass at the time. And I remember him walking into my office with a chart, probably about this thick. And he said, Scott, I want you to see a patient. And as he handed me the chart, it said volume 12 of 12. And that's really how I got into complex abdominal wall, not really with intentionality, but as a result of a clinical need. And I would argue that that very much exists today. And although we definitely had a lot of home runs back then, I would say we had a lot of foul balls, a lot of swings and misses. And our patients really suffered as a result of that. We just didn't know better. At that time, as I ventured into open abdominal wall reconstruction, I did a lot of open anterior component separations. I didn't even know what an A1C was. If I did, I certainly had long since forgotten about it. BMI was absolutely not even considered. Smoking was not a consideration prior to operation. So this whole idea of prehabilitation didn't exist. The techniques that we utilized were time tested, but had challenges, and wound complications were an everyday occurrence. And we were happy to get people out of the hospital, and wound complications were an expectation. So, and fast forward, and I certainly was an early challenger of the transversus abdominis release, as you probably recall. And I was a skeptic adopter, and I still think there's a lot of opportunity to study it more. But, I started doing TAR, I think in 12 and 13. And I sort of gradually introduced it in my practice. And I had concerns about the functionality of the transversus abdominis muscle and the deficit that it might create due to, lumbopelvic stability.
I remember those talks. You can probably still, I still have your
remember
slides.
them too.
I still have slides.
And I think about it. And I think, honestly, at the end of the day, I think the problem is that the deficit created by a large ventral hernia is so significant that the restoration of the linea alba is so much greater that you overcome that minimal deficit associated with the transversus release. I think it'd be important at some point to do studies and really look at patients who have had transversus abdominis releases absent a hernia, to really just to understand what it does and what it doesn't do. But,
Right.
But having said that, I'm all in. I mean,
Right.
last time I did an anterior component separation was quite some time ago. And I went through the iteration just like you did: endoscopic component separation, perforator preservation, the whole gamut. But
Right.
I'm all in. I mean, I
Right.
drink the Kool-Aid.
So, but before we kind of dive into this, I actually have an interesting question for you. As you're an innovator. It's the way I would describe you is a careful innovator. Like every time we introduced different things, you always were kind of like, it's cool. Wait a second. Let's see how it goes. You were always skeptical at the beginning and a lot of different things. And it was really good to have that kind of prove it sort of voice. And we always respected that opinion. But as a careful innovator, what was, again, I'm still doing a little bit of a walk through history. What was bothering you the most? Say 5-6 years ago, you were finishing a work week and you had a full week of OR, you had full week of patients who were happy and unhappy. What were the things about your week that obviously you were happy about good stuff, but what was bothering you the most? What are the things that really were, as I quote unquote, were hurting your feelings?
Yeah, I think there were quite a few elements of what we were doing that needed improvement. I think the postoperative pain and discomfort that we saw from a lot of folks was real. I think we had lack of sensitivity and awareness of opiates. And when these patients had problems with pain, we threw opiate pills at them. We didn't have any concept of multimodal pain therapy. I think that's something that, that really has evolved. I think we were aware of the fact that patients who had these complicated operations needed to pack their bags, and they'd spend, 9, 10, 2 weeks in the hospital. It was a real challenge. And I would say wound morbidity really kept me up at night. You know, it was an expectation that many of these patients with complicated problems would have significant wound morbidity. And it was a major burden for me, but for the patient as well. And I think those were some major issues that needed to be addressed. And I think we've come a long way. We're far from perfect, but those are things that I think we do a whole lot better today than we did, you know, even 5 years ago.
So what were your first thoughts? And I know you were never a big biologic person, like you were using it, but you were never super into it. And I think I was for a period much more into it than you were. But what was your first thought? And we obviously heard your attitudes about physics currently, about bioabsorbable materials. Uh, when the first time you saw it, the first time you touched it, give me your perspective of that kind of early, not experience, early impression.
Yeah, you know, I had the opportunity to get involved with some of the biologic problems during early in my career while I was at the University of Maryland. And I had the opportunity to participate in that original life cell trial. And those were really my early experiences. And it was the collaboration with the plastic surgeons, you know, some of which are now deeply embedded in the life cell organization, that really exposed me to that. And I certainly had some healthy skepticism that we were going to regenerate fascia when we created a volleyball full of mesh and sewed it in as a bridge and thought these patients were miraculously going to heal their hernias. So although I certainly did that in collaboration with, you know, with others, I always had a healthy skepticism of that, having been trained in component separation techniques. You know, I had learned that in my residency, not so much in my fellowship. My fellowship at the time really wasn't a hernia fellowship. It was a minimally invasive fellowship with a significant component of laparoscopic hernia repair. So, you know, I definitely used it. I probably overutilized it. There's no question I overutilized it. I was never a biologic mesh for everyone kind of repair person, but I certainly helped to craft that discussion as to where they should be used. And, if we want to dive in and talk about it, I still think there's a role for them. I just think the role for them today is much different than what we thought it was 15 years ago.
Right. Well, it's definitely, it has, you know, it's been, I can't remember. I certainly had never used it in Colombia, and it's probably 4 years since I've used a piece of biologics. It's been a long time. So even though we kind of used to say, you know, for a moment, AB coding was this new thing that I thought was going to help me with the MRSA sinuses, some active sinus infection, or history of MRSA. But then again, that hasn't been the case. So I do feel kind of much stronger about the fact that biologics kind of had its time and we moved on, and largely because we have an alternative for phasics and absorbable meshes and whatever is yet to come in that field. So, but the first time you used it, tell me about the first time you ended up thinking, yeah, I want to use this product. What was it like? What were your initial impressions, or your initial thoughts, hopes, and kind of, I want
you
remember.
It's funny that you say that. I've never actually thought about that question until right now, but I know exactly the case that it was. It was a patient that I had done a total gastrectomy on. She was morbidly obese. A BMI was probably 50, although we probably didn't measure it at the time. And she had significant wound morbidity post-operatively, and thank goodness she didn't have anastomotic issues. And when she did that, she developed a major wound complication and a massive hernia. And when we ultimately tackled her hernia, we tackled it again while she was still morbidly obese, and we used it as a bridge. We sewed it edge to edge. We used a biologic material, and I honestly had the hopeful optimism that this was going to be a definitive repair for this patient. And obviously it was far from that. That was probably my first experience that, and literally with a wound that again became infected, as so often is the case, the biologic material just disintegrated in front of me. We were just simply debriding it from the wound. So I would say my first experience was far from favorable. And we've all had similar experiences repeated over and over again. So,
so how about phasics? How about phasics? Your first experience with phasics?
Yeah, so my first experience with that was actually as part of a clinical trial. I think I mentioned it briefly in the talk, but I was asked to do the pilot study back in 12 and 13. So we were asked to enroll 30 patients, straightforward hernias, low risk, all Reeve Stopa repairs. So my very first patient was a Reeve Stopa. We defined some high risk criteria, but at the end of the day, they were comorbid patients needing Reeve Stopa with primary or first time recurrent hernias. So we did it. It felt like a piece of polypropylene. It went in quite well, and really had no issues. And I had this sense that this was more polypropylene-like than a biologic. And honestly, that was the experience that I had, that it acted like polypropylene. It responded like polypropylene. It was very different from the biologic materials that we had previously used.
All right. And has that changed? Has your perception of your choice, has it changed kind of deep down in your heart now they have more experience? Were you more reluctant, and are you less reluctant now? You mentioned biologics, you had high hopes that didn't materialize. Was it the case here? You had high hopes and they kind of have been tempered a little bit, or you had sort of lower expectations and now you have higher or kind of better attitude towards? Where are you comparing to your early experience to now?
Yeah, so I think that's a great question. I will tell you, there is one Achilles heel of the bioabsorbable meshes, and I think it can't be overlooked, and that's cost. But I actually think, absent cost, I think bioabsorbable meshes could play a major role in the repair of hernias today. I think the outcomes that we are seeing, when utilized with appropriate techniques, with TAR, with Reeve Stopa, with retromuscular mesh, we're actually seeing outcomes that rival what we see with synthetic mesh materials. So, but you can't argue with the fact that there's a magnitude of cost difference between a P4HB mesh and a polypropylene mesh. So it creates real challenges. And I really believe the frontier of hernia is going to be in precision medicine. We don't know which patient benefits from which repair. And I talked a little bit about that last night. But at the end of the day, there are patients in my mind that clearly need polypropylene, some that need polyester, some that need P4HB. We just don't know who they are. We need to get beyond the fact that one patient gets the same repair as the next just because that's what we do. I think we've got to figure this out. It's going to be complicated. We got to roll up our sleeves and do it. But I think it's a time for precision medicine in hernia repair. Yeah.
Gabe, welcome. I see your question. I'll get back to it because I want to ask kind of a few things, because just to set the mood with Scott, and I have a few more like philosophical questions, and I think so far I've agreed with a lot of what he said, and we might come to the point where we're going to start disagreeing a little bit. And I want to give you a couple of scenarios here, almost like a game. So you have a clinic and you have your first two patients in the clinic. One guy is a year out after your complex abdominal reconstruction, and the second is a lady who is 1 month out. And the guy a year out comes in and he has a recurrence. The lady is 1 month out. You come in and she has major wound problem. So you go back to the office. Think about it. Which one are you more upset about?
I mean, honestly, both of them bother me.
No doubt. But which one bugs you more? Which situation bugs you more?
Today, the recurrence bothers me more than the wound complication. However, I also appreciate that wound complication significantly increases that patient's risk of recurrence. So that bothers me, knowing that they're highly likely to develop that recurrence at a year as a result of that early SSI. But today, I go home and I'm bothered about that recurrence because that's a patient that now needs a reoperation. Right. The SSI at least have a 20% chance of getting away with something.
All right. I'm like that too. So we're not that different after all. I'm like that too. Recurrences bother me, and I think we hate major wound complications, but we've sort of, but when I ask that question to a larger audience, and maybe not people who make hernia repairs their life, a lot of them would not answer that way. A lot of them would say, I can deal with the recurrence, I can send it out, I can figure it out. I just really don't want bad wound morbidity. And I think when we talk about these things, we have to remember that there's this group of people who are live and breathe kind of hernias, and there's an average guy or even above average guy or gal who I think will have different perspective. And it's very important for us when we make those choices and give lectures on the topics to understand that everybody's different. And there's what bothers us more is probably not an average answer. I have another scenario for you.
I just wanted to comment on that. I think it's interesting because I think you and I definitely would agree that we give every patient the best operation we know how to do.
Mhm.
And the real challenge with that is knowing that the second go round is never as good as the first operation. So when we see these patients that have had 3, 4, 5, 10 operations, sometimes it's hard to fathom that someone has had 10 prior hernia repairs,
Right.
but they have. And we want to do an operation that is, sort of
Right.
quote unquote bulletproof. And if my operation doesn't work, I know the second time I do it isn't as good as the first time I did.
Right. No doubt. But it's a really important point as we make technique and mesh choices to understand your own fears. I think when people are making those choices, they have to understand some of that and what they might be facing and how they're going to deal with this. And I think that's just one way to think about it. The other way I wanted to, so I was involved in when I was in Cleveland, we were doing prospective randomized trial of Stratus versus soft mesh. So we were doing really kind of, true
Gary,
prospective.
can you explain for the internationals what that means? Soft mesh?
So we were using a porcine, non-cross-linked porcine biologic versus macroporous polypropylene mesh. Two meshes, both we're going to use as a sublay technique. And this was going to be all for only clean contaminated case in the setting of kind of real infectious or non-clean cases. And at the beginning of the study, so the randomization would occur at the time when it was time for the mesh. So you do a portion, you do posterior component separation, you close your visceral sac, you're like, okay, I'm ready for the mesh. The nurse would come in, open the random envelope, and they would tell you which mesh you're about to use. And early on in the study, we would get patients randomized. So you just took out somebody's colon, you did, take down of ostomy or resected the bowel, and then you're waiting for this envelope, and you kind of deep down rooting to be randomized in the Stratus group because you don't want to like push the envelope and you get Stratus. So you're like, okay, good. So you do your thing. And then over the course of probably 6 months of the study, we noticed our attitudes began to change, that every time somebody would get randomized to a biologic mesh group, you'd be like, and every time somebody would you were like rooting for one thing or another. So I want to put you in a hypothetical prospective randomized trial that you're doing tomorrow, and you're doing ostomy takedown on a BMI 30, kind of non-smoker, well-optimized patient. You just took down the ostomy. They have a large midline hernia from a previous emergent colectomy, and you're doing a TAR. You decide to do it as a one-stage repair, and you finish your posterior component separation, and you say, can I have the envelope, please? And they're about to open the envelope, and you're going to find out, is it going to be Phasix or is it going to be a polypropylene mesh? Which one would you be rooting for today or tomorrow?
Yeah, so interestingly, in 2020, I'd be rooting for P4HB.
Okay.
Because we're seeing our outcomes.
Just so you know that we have some special guests. Paulie was going to say he was going to vote soft mesh. So we've got a little debate.
All right.
And I think that the honest answer is we don't know. That prospective randomized trial has not been done yet.
I know. Well, no, listen, it's hypothetical. We have, some kid gets appointed to be a professor, and like 3 days later, he contradicts you. That's all.
No.
That's what happens. So this riffraff, when they get promoted to academic heights, they all of a sudden feel like they need to contradict important people like us.
We also have Gabriel Aravalo online. And Dr.
And if that's Paulie that we're talking about, just remember, I wrote your letter.
I did too.
Whatever he's doing, he doesn't even want to show his video or his voice. So I don't know. You may not keep him.
You don't know how he looks today. Anyways, there you go. That's from 4th grade.
Picture.
Exactly.
It's not current.
This is middle school graduation. So Gabe had a question. So Scott, interesting. So I don't know. Obviously, we should have a prospective trial like that. I think it'll be an awesome idea to truly figure this stuff out well, to really put it to the test. And I think I'll be all for doing this as a part of the trial in the real patients, not necessarily something crazy, but in real life patients who and we could answer an important question. So I'm with you. I think I'm probably a little different. So today, I'd still, given my experience, I'd still be secretly rooting for a polypropylene mesh, but I wouldn't be disappointed if it was if I would get an envelope with P4HB. So,
and I think it's important to really factor in the other surgical variables. If I was in that situation and I was not able to close the fascia at all locations with a suitable quality or with undue tension, there's no question in that situation I'd be rooting for soft mesh.
Right. No, I'm giving you're able to close. It's all going to be good. We just need a mesh.
Right.
So Gabe, for some reason, in 6 months of his fellowship with me, he still didn't learn this, but he's asking what mesh to choose for patients of childbearing age. I guess men and women, or just women, Gabe?
Just ladies.
Just the ladies of childbearing age. So would you ever today do a lap ventral or any synthetic repair on a really young woman who still plans to have children?
Yeah, of course I would. And it really depends on the characteristics of the hernia. I think a small and modest size hernia, I think a polypropylene mesh is absolutely acceptable in those individuals. I think they need to be counseled regarding the potential for problems. Anyone that's seen a patient who's pregnant who has a polypropylene or a permanent synthetic mesh and has pain will have trepidations. But I think there's a lot more patients that become pregnant after a synthetic base repair that don't have problems. What I wouldn't do is some of the repairs that I did 10 years ago or 15 years ago, where I took a gigantic piece of mesh and wall-to-wall carpet, so to speak, or the astrodome we often called it, and lined their entire abdominal cavity with synthetic mesh.
So I think it's interesting that here I'm a little bit more aggressive than you. I actually stopped using permanent synthetic in young women or women of childbearing age. I'll talk to them about it. I'll talk about primary repair or repair with basics, either restop or onlay. And I'm really I've been sort of interested in this topic for many years. As you know, at my conference, I always have this lecture, and I was always amazed how this topic was not understood, how it was not addressed, investigated. You'd think an amount of young women who have hernias would have this solved, and it wasn't. And I remember Brand was on our panel, Brand Matthews, and obviously who is a thoughtful hernia surgeon. And then the question was, how would you approach a woman with childbearing age who wants to get pregnant? And he said, it doesn't matter. It's whoever goes first. He said, if I'm first, I'm fixing it anyway. If she, so it wasn't a consideration. And it was puzzling to me that, it's a really unique group, and it stuck with me. And since then I've been paying more and more attention, and my gut feeling is, and my sort of some of the evidence that we have today points to me that I think Phasix is one of the better, a young woman with hernia who might get pregnant is probably one of the best candidates for non-permanent mesh.
Can I butt in? Can I ask you guys a question? Serious question about Phasix. It's a rumor, Bard's our sponsor, but isn't there a little evidence that the stuff is gone after 2 years and the recurrence rates may be the same as if you didn't use it? Or is that all myth? Like, what happens at 3 years and 4 years after Phasix?
Well, Scott's in his talk, I'll let Scott talk about it. They've taken it out past the expiration, quote unquote, date of Phasix, and he'll tell you. Scott, why don't you tell us about life after 18 months?
Yeah, so the 18-month data was published, Surgendo, 9% recurrence rate, 6% in a retrorectus repair, 19% in an onlay technique. The 3-year outcomes had I believe, I shared it in the talk last night, based on modified intent to treat, I believe it was a 17% recurrence rate. Based upon a Kaplan-Meier, I believe it was a little bit higher. I think it might be 21% at 3 years. And the 5-year data is now in, and we are preparing that right now. And unfortunately, I can't share that with you, but it's very optimistic. So I agree with you that the meshes should be completely resorbed at 18 months. I would think 24 months would be an outlier for complete resorption. And I think we're seeing very good outcomes. without a permanent synthetic mesh. And, and as I said last night in the talk, I think it's important to realize, the best data we have, which is the Lewandike data, which is out to 7 years, has a recurrence rate with synthetic polypropylene mesh. Yet there's still a group of patients, 37%, that don't recur with a suture-based repair. So I think we need to improve upon the suture-based alone repair and recognize that there's some mesh complications that are occurring and really try to figure out what that sweet spot is. So,
But to be honest with you, I think
quick question.
Lewandike's underlays with like kind of 3 centimeter overlap. I'm not, and it's kind of it's not as discussed. I don't know how to judge the quality of that surgery.
Time out. Somebody has hijacked Dr. Paulie's camera.
Where?
What happened to Eric?
There you go, guys. There you go.
Oh my goodness.
There you go. Hey.
I didn't mean to stop this, but let me ask you a question seriously. Dr. Roth and
That's
Yuri.
a COVID face.
Randomized trial of a transversus abdominis release with no mesh or phasics. Recurrence rates are the same or different? What do you think?
I am convinced it will be different.
Okay. And Dr. Roth?
Absolutely. I think it's interesting that the transversus abdominis release has never been studied absent mesh. We've sort of made the leap to transversus abdominis release with mesh. There's quite a few studies looking at the anterior component with and without mesh, and there was a benefit. And maybe we've applied that principle as we've done the transversus release with mesh. There's no question in my mind that there's a value add to adding an absorbable mesh to a TAR.
Brian, you know who taught us that the answer to your question? I think BioA. I think the fact that the COBRA trial demonstrated a recurrence rate that was less than 80%, and I had prospectively, I was predicting that it was going to be 80 to 90% when they offered me to participate in that study, and it was going to be a BioA that we've studied in the lab. I'm not sure if Scott has, but you know how it acts in an infected field. It looks like snot. And all of a sudden you say, you're going to be putting this in a contaminated field, the mesh that goes away in 3 months, 3 to 6 months, completely gone. And it's going to make this complex repairs solid. And the recurrence rate was 17%. Again, we can criticize a little bit the methodology. There were no CT scans, so you can add a little bit, but still the proof of principle was done by that study. To me, that study's value is proof of principle. We learned that early reinforcement with kind of mesh, early repair stabilization with any mesh, even the one that goes away so quickly, plays a role. I think the improvement of phasics is the fact that it engrows, it has pores, but it also lasts longer. So I agree. I think putting it it's probably, we don't know how it compares to synthetic, but it certainly is going to beat out nothing.
Okay. That's sort of an important question.
Eric, what do you think? Eric Paulai. Is he still there?
Yeah, I'm still here. No, I agree. I agree, Yuri. I think that, I was in Cleveland, I think, just as you guys started the COBRA trial, and kind of had the same thoughts that, like, I'm not sure that this is going to do so well in contaminated fields. And when the data came out, it was very surprising that the recurrence rate was as low as it was.
I never put a single patient. I thought it was crazy.
Yeah.
And they proved me wrong. And the truth is they proved me wrong to a degree, but I think it was good to have people who were pushing the science and testing it, because they made that leap that I think created the background for us to what we think and know now about slowly absorbable meshes. So I do think it has a huge value.
I'm not going to sign up for the TAR with no mesh trial. I apologize in advance.
Why not?
Well, it's so much work to do a transversus release, the primary goal of which, one of which, is to create a sublay space, right? You're creating a pocket within which to put mesh. With an external oblique release, you're alleviating tension, but you're not making an ideal place to put mesh. And so, I don't know. I just don't think that I would do it. If I was gonna do a component separation without placing mesh, I'd just do an external oblique release.
I'm with Eric. To be honest with you, I'm with Eric too, because I think when you have some cards that are dealt to you, and you all of a sudden have an ace there, it's hard to just throw it away. I do think Phasix versus polypropylene would be a cool trial, provided that people understand limitations, because the benefits are huge.
Let me ask you a question back. Can I throw something at you?
Sure.
Have you ever had a transversus release with polypropylene that you've had to remove the mesh?
Yes, I had. Up until recently, I was saying no, and Gabe is sitting there because he removed mine since I left, because I used heavyweight polypropylene. Somebody who had multiple infections in a setting post-tram. I mean, she had the whole 9 yards, and she had like small problems, but at the end of the day, that heavyweight polypropylene never ingrew, and they had to go in and pull it out from like a lateral incision. So we've had complete mesh removal, and that was probably N of 1. I had a patient who had perforated diverticulitis like 2 months post-op. I had to go and remove good portions of the mesh, but that's pretty much it.
But never with macroporous midway polypropylene.
No.
Yeah. How
It's
often
hard to remove it. It's hard. It's like after the first week when you go in there, I've had to go back for like bleeding. I had to go back for, early postoperative bowel obstruction. It's hard to remove it, even if
Yeah,
you
no,
try.
I'm with you. I'm just curious. But the follow-up to that question is, how often do you see someone present late with a draining sinus or a late infection associated with that mesh? Have you ever seen that?
So heavyweight, yes. Lightweight, I don't think so. I don't think I had a latent. I think once it heals up, the good thing about polypropylene, especially macroporous, it's either gets infected or it grows. It kind of doesn't do both. And that's different from polyester that could be fully grown and yet with chronic draining sinuses. But I also move strategically every so often. So
So I'm with you, and I certainly have jettisoned my thoughts on using heavyweight polypropylene. I used to have this sense that if it was really a tough hernia, to use a heavyweight polypropylene because of that durability. And I just don't think that no longer has a role. I pretty much would never use heavyweight polypropylene in a ventral hernia TAR type situation. I don't know that I've seen it with a lightweight polypropylene as I really, really think about it. And I think that's a really key point, that if you're going to do these operations and you're going to use synthetic mesh with higher levels of contamination, it's got to be with the macroporous material.
I use it in several scenarios. One, big flank defects. I feel the flanks that you never get good fascial position, so I will use that. And I just recently used it in a lady who had pretty much no abdominal wall after major operations, neck fascia, history of anterior abdominal wall, had multiple rotational flaps. She had tension fascia lata. She was like 4'11", big loss of domain, and I knew I wasn't gonna. There was nothing to restore linear elbow. There was no tissue that would qualify for contributors to linear elbow. So I knew it was going to be, the mesh is going to be a major thing. And I used heavyweight polypropylene. I didn't quilt it the way I used to. I overlapped it with some stitches, but like, 30% overlap. And this, now when I feel like I need a little bit heavier mesh, most of the time I just use home plate. And I feel this is my, poor man's macroporous heavyweight polypropylene. You just double up or overlap a little bit of your macropore stuff, and it works great. It really does fuse, and it provides, if you look at the numbers, it's as heavy as Marlix. And the reason I also think it's worse, if you look back at PCO, Paritix PCO, you remember it was a 3-dimensional mesh. We always liked it. It was kind of spongy. There was a point to that. And now I think about it, there was just 2-layered mesh connected with just some stuff. They were just making it stronger. So the precedent of mesh overlap or kind of layered meshes has been said a long time ago. We're just called 3-dimensional mesh. So I'm creating my own 3-dimensional construct that's a heavyweight polypropylene by just overlapping synthetic meshes. Eric, you do that a lot? Mesh overlaps?
Yeah. I mean, obviously I learned doing that from you, but I do like it a lot. When I've had problems with it, it's always been not attributable to the overlap of the mesh, but to some other issue. Like, I had a bowel injury in a patient, and the mesh got infected, so it was not specific to the overlap.
Right.
the only and I like doing that because that also allows me to span big gaps without using any transfascials for some of these, because I used to worry about, like, I was cheating the mesh on the upper edge, so I'd put a bunch of transfascials in. And so by being comfortable overlapping, I've also eliminated a lot of upper abdominal transfascial sutures as well.
Let me ask you, so why not use, and again, I know Bard doesn't make one, but home plate versus a 50 by 50? Talk to me about, I mean, I would choose a larger mesh as opposed to the 2 sheets with overlap in a home plate fashion.
To be honest with you, I actually would argue the opposite. The way the lower abdomen is.
He didn't pick a point. He was asking what you like, but yeah.
No, but I think even if I had, the lower abdomen, the way the pelvis is, the 30 by 30 kind of fits that pocket really well. And I like the square aspect when I go really, the upper abdomen lends itself better to a square mesh. I like to go to, above the xiphoid and kind of have the square, that sort of line of the mesh that goes from one hemidiaphragm to the other one. So I actually like, beyond the overlap, I like the actual shape of the prosthetic that I'm implanting. If you have 50 by 50, you would have to sort of either trim it on the top or still have this cheating area on the angles that doesn't go to. I don't know. I like the shape of a home plate as I imagine what I'm trying to overlap, as I imagine the visceral side.
By the way, Yuri, we've been hacked.
Again,
this is the problem with Zoom, because we've got a plastic surgeon hacked us. We have Dr. Butler from MD Anderson who's chimed in.
Right.
Apparently, he's the one person in Houston
What does he
without
know?
COVID. One person in Houston without COVID, and we have David Laurier from California who also hacked.
Oh, awesome.
I don't know if you can see the screen.
I don't see them on the screens, but certainly would welcome them to interrupt us and pipe in. I do have a question from the audience that I want to ask here. Our friend Ramesh from India is asking, if you need to bridge and you have a TAR you need to bridge, would you still use phasics? Scott, that's for you.
I'll see if that's for me. The answer is absolutely not. I think there's different degrees of bridges. I think, unfortunately, sometimes you end up with a bridge and you were hoping you wouldn't. You've done your TAR, you've assessed your tension, you've maximally dissected, and you close fascia, you're left with a small 2 or 3 centimeter defect.
Why is everyone talking at the same time? Seriously.
Who's asking that?
So I would in those situations, I would accept a small bridge and move on. But if I had done my releases and had a large defect, I would absolutely avoid an absorbable mesh in those situations. We don't know how it's going to behave in a bridge situation, but I strongly believe that the risk of recurrence would be significant. In that
So essentially, you have a patient, you have concerns about wound morbidity, you're planning to use phasics, you do your surgery, and you're like, this is not going to come together. So you would switch gears. You were planning to use phasics, you were concerned, obviously, for a reason, and now that you can't completely restore lineal alba, you would switch gears.
Absolutely. I recognize in those situations that there is a risk of mesh infection, chronic sinus, but I also realize that patient is having their best chance of a long-term durable repair today. Right. And in that situation, I'm going to change gears and I'm going to use polypropylene. And every single consent form that I write for in the operating room says bioabsorbable or synthetic mesh. I would not leave that off. There are rare situations where patients say, come hell or high water, I don't want a piece of permanent mesh. That's a different situation.
No, I'm with you. It kind of goes to what you have said before about.
I lost you, Yuri.
Still, I'm right here.
Yeah, we got you, man. That's okay.
Okay. So I have another kind of somewhat philosophical question that I ask myself that a lot. And I've evolved in certain ways accordingly. 5 years ago, tell me something from what you used to do routinely 5 years ago that you would never want in you or your loved ones.
Well, probably longer than 5 years ago. But I think a lap IPOM bridging ventral hernia repair. I would never want that for me, my loved one, and I wouldn't do that for someone today.
How about
And
lap
that's something
IPOM non-bridging?
Not a bridging. Would I do a lap IPOM non-bridging?
Would you want one in you or your loved ones, a
No,
20
no.
by 15 centimeter synthetic IPOM?
Absolutely not.
This is not a fair question with me hosting. So I would take that.
Oh, I'm sorry, I didn't even mean it that way, but now that you mentioned,
For sure, I would do it because I do that all the time. I still have proof, unless Yuri, you can show me some of the patients of mine coming to Columbia to get their mesh out. But this operation is durable, it's still durable, and it works, and patients recover well.
your patients would not go to 168th Street if their life depended on it. So.
That wasn't the question, Brian. He didn't ask the question, are the outcomes good? That wasn't the question. He said, would you want it?
Well, okay, so for an umbilical hernia, how would you want that fixed?
No.
Let's ask the panel, umbilical hernia, 2 centimeters, how you fixing it? Let's start with Dr. Butler. Are you there, Butler?
It's too small for Butler.
I am here. Do you hear me?
Where is here though? Are you like really here or just?
Yeah, I'm really here. You finally let me in.
So belly button hernias, how are you fixing them?
Doc, how are you not familiar with Zoom?
All I hear is like 1,000 people talking.
Well, turn off your background noise. Like you have it's your computer, dude.
Or take your Risperdal.
Yeah, I'm here.
Do you know Dr. Roth, by the way? Have you guys met?
Yeah, of course I do.
Of course, we've shared several meals.
All right, good. All right, so listen, belly button hernia, man. Come, David Laurier, how about you?
It's going to be a mesh repair, most likely retrorectus, and if it's a small one, unless it's 1 centimeter, then it's going to get a mesh, and it's going to get a mesh and reinforced repair.
Got it.
I'm not like that, guys. I think we overuse mesh for umbilicals. I honestly think if you do it under local without people bucking too much after operation, we could expand those. Yeah, I even use Danish data to come up with the opposite conclusion. I think 85% success rate is pretty good for me for first try. I'm just very reluctant to put meshes for small problems. But again, it's this highly debatable topic, and I think the smaller the hernias, the more debate we're gonna have.
Sounds good. All right, let's go back to Dr. Roth. Dr. Roth, you published a paper about parastoma hernias recently. Can you summarize that for us?
Sure.
We get a question about parastomas all the time.
Yeah, sure. We looked at our 10-year experience of parastomas. We used the same data set and mined it and published 2 papers that really looked at different things. First off, we used the European Hernia Society classification. We looked at 1s and 2s versus 3s and 4s, small hernias versus big hernias. And we postulated that the bigger hernias were going to have more problems and poorer outcomes. And that absolutely wasn't true. The 1s and 2s had the same recurrence rates as the 3s and 4s. So you could argue that we do a bad job with the 1s and 2s, or we're doing a great job with the 3s and 4s. But the bottom line is that the big hernias and the little hernias do exactly the same. So the takeaway for me is the fact that peristomal hernias are a challenge, period. There is a high recurrence rate. The median time to recurrence was about 3.9 years. So that's very different from what we see with our open ventral hernia repairs, much higher recurrence rate. So I set the stage with our peristomal hernia patients that, look, this is a chronic disease. It has a high recurrence rate. You will be back. We need to make sure that they understand that. When they have a stoma, they have a high likelihood of a hernia recurrence. When they develop that recurrence, we need to treat them to the best of our ability, and then only fix them when they're highly symptomatic. And when they're highly symptomatic, then we need to do the best operation we can, recognizing that even with that, they have a higher rate of recurrence. As I said, the other piece of the data, we looked at our laparoscopic sugar bakers as relative to our open repairs. Now, there are some real challenges with that because of the fact that the patients who got laparoscopic sugar bakers tended to be less complicated hernias than the patients who had the open hernias for complex abdominal wall reconstructions. But we did our best to match those. And interestingly, we found that the laparoscopic sugar baker repair had a longer time to recurrence than the open repairs. So it really reinforced that over time I've sort of have changed what I did. You know, so a great example of a question you said, what did I do 5 years ago that I do differently today? You know, I used to do all lap sugar baker repairs at any expense. As I learned the tar procedure and really became familiar with, you know, utilizing a tar in a peristomal defect, I really adopted that. And now I've sort of switched and I have much more of a hybridized approach where I use sugar baker when feasible and utilize the open techniques when it's simply not possible. So that really has evolved.
I think we can talk about peristomals and especially frustrations with peristomal repairs for many more webinars than just this one. Scott, are you familiar with something called Madrid modification of TAR,
I am.
Miguel Arena?
Yes.
What do you think? So they utilize, as you know, not only slightly different variation of the release, but they also use a piece of BioA on top of the visceral sac prior to putting a synthetic mesh and putting a lot of theory behind of reinforcement of the visceral sac with the absorbable mesh or BioA. What do you think about that? And if you kind of like this idea, what do you think about physics in that space underneath a synthetic mesh?
Yeah, I think that's an area ripe for discussion. This enters the concept of hybrid meshes, and essentially they're creating their own hybrid mesh, and they're trying to alter the wound healing cascade. In my opinion, I know there's been some basic work that's come out of the McGowan Institute looking at the macrophage response associated with P4HB, and they talk about the M1 and the M2 macrophage, and trying to reduce the inflammatory component of wound healing through the utilization of P4HB. And I think there is an opportunity to maybe augment the wound healing cascade associated with a synthetic polymer during a ventral hernia repair. Obviously, it's way too early to comment definitively to say whether that makes sense or not. But I think there's a lot of opportunity to study that further. And I do have some optimism. And I think newer generation materials that augment wound healing are going to be important. There was a lot of interest a few years ago with some of the meshes about local delivery systems and delivering drug. As you know, I've done a lot of basic science work looking at doxycycline as an MMP inhibitor as an attempt to augment wound healing following a ventral hernia repair and change collagen deposition. So I do think moving forward, we're going to see polymers, and the way we treat polymers is not going to be simply to implant them with the polymer alone. So, I think stay tuned, but I do think there is a role for that type of repair and that type of technique. Today, as we sit here, can I tell you it's better than a traditional TAR as you and I would do it? I can't tell you that. And would I do that today? Absolutely not. I think it's added cost without proven benefit, but I think there's some promise with that. From a technique perspective, if you wanted to go there, I don't understand it. I think it makes the operation more difficult personally. I prefer to do the technique as you described it, Yuri.
Yeah, I mean, there's some benefits that they claim, and Miguel is very passionate about it, and I think it's another long discussion. Conrad brings, and
one thing I went over there and watched him do it, Yuri.
Yeah.
We did a couple cases together, and I followed the outcomes, at least for the case that I scrubbed with him on, and it's the real deal.
Right. It's very similar.
Cleveland of Spain, man.
It's very similar to what we did with Hannaford in the fellowship. It was very similar. We didn't call it TAR, but it was very similar how we got into preperitoneal plane down low, dissected up, and then moved medially. When we could, we stayed preperitoneal, and when we couldn't, we cut the posterior fascia, and we were cutting, occasionally we're cutting the muscle that Todd would call serratus anterior. But I think what Miguel does is very similar to what we're doing in Charlotte, and it worked well. So I'm not saying it's a bad technique. It's not something that I do. That's all. But let me switch gears a little bit, because obviously we can't have a complex hernia repair discussion without bringing up robotics and the role of expanded role of kind of minimally invasive surgery as well as robotic surgery in complex hernias. And our robot kid there, Conrad, is asking a question: how do we extrapolate data on wound complications, on preoperative optimization to patients who no longer going through big midline cuts, who are now getting minimally invasive repairs? Can we use the data that we have for open repairs to robotic repairs? And also, does the increase in robotic repairs change the equation a little bit in our fears of complications and our mesh selections?
Yeah, I mean, that's a loaded question, and I think all that evidence continues to evolve. I would argue that you probably can't use the open literature as you study robotic repairs, because it is different. I think you are cutting the same muscle and you are achieving the same release, but I do think there is a physiologic difference because you didn't make that laparotomy. And we see that patients go home in a day as opposed to going home in 4 or 5 days. And really the only difference is that we're not making a large skin incision. So there is some physiologic difference associated with that laparotomy. So I think you should be cautious in utilizing the open literature as it applies to robotic repairs. As it pertains to mesh selection, unquestionably, the fact that we can avoid wound complications and do fairly complicated operations is a game changer. So now we can use materials that we wouldn't have dreamt of using because we know that risk of a wound complication is significantly lower. I would argue it's still not zero, but it is significantly lower. So I think all that needs to be carefully considered in your approach. I still believe not every hernia can be approached with a robotic technique. And
of course,
I have a very specialized tertiary care quaternary referral practice. And there's just patients that it's not feasible.
I'm with you. Listen, I'm a huge fan of robotics, but I still do a lot of open stuff. But along the lines before, so do you think there's a huge role for absorbable mesh in robotic surgery? Slowly absorbable mesh?
The short answer to that is it probably is not as important as it is in open operations. I think one of the key advantages of using an absorbable mesh is the mesh infectivity advantage. There are other advantages beyond that, potential for fewer adhesions, but when you're doing a robotic repair and if you're placing it in an extraperitoneal pocket, the adhesions you form to it are quite minimal. So I'm not so sure there is the same advantage in a robotic repair as there is in an open repair.
All right.
So look, Yuri, you have time for one more question from the audience. Otherwise, we're reaching the end of our time here.
What do we have? While we're waiting for the audience, I have saved the last question for Scott, and he may or may not be ready for it, but it kind of brings the loop back to us from 10 years ago when we're in 2010, 2011, 2012, where really doing surgery every day, thinking we're the utmost experts, providing really the cutting edge care. And if you ask me at that time, I would say I have it all figured out. I kind of know what to do for almost every problem. And I literally do nothing the same way today like I did in 7-8 years ago, which is not that long ago. So the question to Scott that I have is, so what do you have? What do you think is going to be in 2025, 2027? What do you think crazy stuff we'd be doing? And certainly the stuff that we wouldn't be doing from today, if you were to guess.
Yeah, I certainly have some things that are available now that haven't quite been widely adopted. And I would start by saying a totally extraperitoneal transversus abdominis release is something that I'm training our residents and fellows in, and they're taking it to their institutions. And I think we've demonstrated by doing that now for the past 5 years that it's completely feasible, that we can reduce the need for lysis of adhesions. We can not completely eliminate, but dramatically reduce the likelihood of an enterotomy because we simply don't enter the peritoneal cavity. I think that's going to gain adoption. I think as surgeons see it and they do it, they think, wow, why am I spending an hour or longer risking enterotomies, lysing adhesions? We're seeing it in robotic repairs with ETEPs. We're seeing it with laparoscopic repairs with ETEPs. Why not with an open repair? Why do we need to enter the peritoneal cavity and lyse those adhesions? And the answer is we really don't. And I think that's a significant innovation. And I'm optimistic that in 2025, we will be doing all of our ventral hernias in an extraperitoneal fashion.
I believe that.
Cool.
Hey, by the way, Scott, Damon Simpson wants to ask you a question. What's your first choice of mesh for lap sugar baker?
That's the one time I still use PTFE.
PTFE for lap sugar baker.
The white stuff.
It's the one time. And again, we can get away with it because the incidence of infection is so low.
And what about you, Yuri?
You know, I I used to be like Scott, but now seeing, having adopted Eric Pauli's repair and putting synthetic mesh and extraperitoneal space and doing Pauli repair and allowing the segment of bowel to be on top of the mesh, I have been using Ventrolite. Kind of
Got it.
heavy, you know, I have less fear of that segment to be adherent to mesh.
Got it. Well,
Well,
listen,
Ventrolite, that's a heavyweight material, heavier weight.
Midweight.
Midweight.
and there are a lot of surgeons out there that don't think it matters what you put in. So we got
It
a
all
lot-
fails. It all fails.
Listen, I cannot wait to log back on in 5 years and see us say that, listen, we're doing nothing today that we did 5 years ago.
I know.
You know, that'll be amazing also.
I'm sure that'll be
I'm
the
gonna
case.
log off soon. I want to know if Dr. Roth and Dr. Novitsky, Dr. Lurie, you're the last one on. Do you have anything else you want to add before we finish this live broadcast? Final comments.
I think it's been great. I personally will say it's been great. It's great talking, and I had probably 3 drinks during this hour, so it's been a great time.
Dr.
David,
Lurie, anything
David?
else?
Very nice, guys. Thank you very much. I think just as a final comment, I would jump in and say we all, around the country have different practices. Most of the guys on this, you guys see end stage, tertiary, nightmare stuff that's been redos, and hence a fair amount of open stuff. Those of us that have a little bit calmer practice in that, I think, Scott, I love your idea of tailoring. You said it in better ways to the patient. And so there is a role, and Brian, you alluded to this, and I like it. There is a role that we would do a TAR in a certain patient with a well-done component release where you mitigate so much of the tension that we may not need a long-term mesh support. We may need a short-term mesh support. For some of those patients, that's not your blown out end stage patient, but there's a select group of patients that's going to do well with that. And that may be where some of these
It's time to study. That's the next study, guys.
And I
No doubt.
really, just to piggyback onto what you said, I mean, there's no question. 2025, I hope we look at precision medicine in hernia repair. So we have the right technique, the right biomaterial for the right patient. And I think that could be the innovation that would be absolutely revolutionary in hernia repair.
Yeah, we'll be saying, remember the time when we used to think about what mesh to choose as opposed to just like putting in some data and getting an answer?
Scott, you handle a lot of tough hernias. You're very lucky that you're actually in Kentucky where you've got bourbon in your backyard for when you get home after these long cases. We are all jealous. I can assure you of that. We hope to come visit you. Here's a toast to you.
Cheers.
The glass you can't see, but
He's the only one who's not drinking, mind you.
And that was my bad. I'm not on call, so that was my bad. But there is an open invitation to come to Kentucky. Plenty of room. Stay anytime, and I'd love to have some drinks with you.
All right.
stay online. So for the audience that's logging on at the end here, Dr. Roth will be online to answer your questions. Just tag him. He'll get back to you as soon as he can. I know you have lots of questions. He is on the IHC. On behalf of the IHC and our board and all of our investors, I want to thank you. I want to thank Bard for coming on. This is really a tremendous gift for us. I just learned a lot, and thank you to everybody. Have a great day.
Cheers.
Thank you.
All right.